Thank you very much for the invitation to Vienna. I'm actually not so far from Vienna, 300 kilometers upwards, Danube River in Bavarian forest.
Oh, okay.
These are my disclosures. My talk is going to be about XLIF approach. XLIF approach was introduced beginning 2000 by Luis Pimenta. It was an alternative to ELIF in lower levels of lumbar spine because you have some disadvantages. For example, if you have obese patients, at this procedure you have no vessels preparation. You have a revision surgery from ELIF approach. It will be life-threatening, and you have inflammatory changes. The vessels are stuck to the spine, so just to prepare it is very, very difficult. So there are some drawbacks from XLIF 2. This is a sophisticated technique. You need special instruments, learning curve. Alphavis 1 is not possible because of the iliac crest, but there is some solution with XLIF approach. You need a neuromonitoring personnel, and of course, the most critical point are neurological deficits after the surgery. As you see, no roots because it's a transpsoas approach. Now, if we look at the literature, you have the incidence of 0.7 to 33% of neurological deficits after the surgery. So, what is my experience? I launched a study, prospective study in 10 years with 364 patients with mean follow-up of 19 months. So we recorded the surgery time, blood loss, of course, neurological outcome. In the patients with deficits, we had at least follow-up of 12 months. Of course, radiological findings and complications. Now you can see here the distribution of the indications. Most of them were degenerative, of course, followed by discitis, trauma, and 6 cases of deformity were not really deformity department, but we have operated on 6. Now to the operated levels, the most operated level was L4-5 and most challenging, of course, because of the iliac crest and of the nerve roots, which are very close. And the most procedures were, of course, monosegmental. We have even three segmental. So what about the results? All in all, if you're skilled, you need for the surgery less than 1 hour. The blood loss is not a question, not more than 150 millimeters. And in our study, in 31 patients occurred neurological deficits, in 21 transient, and in 10 persistent. 2 surgeries has to be abandoned because I was looking for the pathway 1 hour and I didn't find the pathway, so I abandoned the surgery and interrupted it. And the other 1 patient, I have just turned around it to the other side and performed the surgery from the other side, and it worked. So if we look at the patients with deficits after the surgery, so motor deficits were persistent in 1% of the patients, 4 cases. These patients had mean follow-up of 18 months and sensor deficits in 1.6%. This patient has mean follow-up of 15 months. And in 21 patients, they recovered fully in 3 to 12 months with the deficits. So now to the results, of course, we had some complications except of these deficits, cage subsidence, loosening, pseudarthrosis, deep infections with revision surgery, malpositions. It was at the beginning, if you're not scarred at the L4-5 level. Incisional hernia and nerve root injury, 1 nerve root injury. It is interesting. So all in all, we had complications, neurological complications in 34 complications, all complications, 35 patients. It means 9%. And in 10 cases, it means 2.7% revision surgery was required. Very interesting thing, the nerve root injury which occurred, and I've seen the injured nerve, there was no deficit after this. I cannot explain it, but it's true. Now, take-home message. So for me, this is a very safe procedure with 9% of complications, revision surgery in 2.7%. With only 1% of motor and 1.6 sensor deficits. You have no vessels preparations, no excess surgeons like in the US. It is for me a really minimally invasive procedure. If you completed the surgery 10 o'clock, 4 o'clock, the patients walk around and notice nothing. And it's short surgery time with sufficient in obese patients. And this is splendid for deformity correction. You have big footprint cages with less subsidence, but don't believe the device uncritically like this injured nerve. And neuromonitoring and equipment is mandatory, so no surgery without neuromonitoring. Retraction time is critical, it is about 20 minutes. Thank you very much.
Thank you, Dr. Moszko. Some questions from the floor? Or we have online questions. 2 questions of the same topics. Do you use standalone cages or add posterior instrumentation?
Pardon?
Do you use standalone cages from the lateral approach,
or
no, do you add
one picture was standalone, but it was performed after the surgery. I always recommend to support it from behind. I do not perform standalone procedures. Because of subsidence, you will get subsidence.
Maybe one question, you said they all get up at 4 and walk around.
If you completed the surgery at 10 o'clock in the morning, if you come to the ward, they are walking around. So for me, this is a less invasive procedure because you have performed a fusion and the people walk around.
I agree with you, less invasive procedure, but my patients sometimes, they have some iliopsoas pain, at least that's how I interpret it, the first few days.
Yes,
not all of mine walk around at 4
Not
4
all
PM.
of them. Not all of them. Some of them have problems because of the psoas.
Exactly.
So this is not all of them. They have some of the psoas, the section, they have some problems, not such euphoric that everybody's walking. No.
Okay.
Some of them. But most of them are very satisfied and
There's a question from the floor.
Just speak. Try to. No?
Yeah. Okay, Professor, I want to ask you, is there any level that you see more complication like L4, L5, or do you still recommend doing XLIF in L4, L5?
L4, L5 is the most challenging. First of all, because of the area crest, you need a band instruments. This is you can have a wrong way just to insert the implant into the L5. This is very challenging, mostly at the man, which have a very high iliac crest. But I can tell you, the nerve injury happened at the level L2-3.